Dr. Kutak.
Hi, everyone. It's so nice to be here today, working with y'all and talking to you about death and dying with specific attention being paid to the concerns brought forth by COVID-19 or another pandemic that might emerge. I want to begin by thanking the Mental Health Technology Transfer Network and thank the invitees for having me here. Okay, so to begin, I want to make this interactive, and so I have embedded some polls within the presentation. So actually, this one says text, but I don't want you to text. On your phone, I want you to go to this website, pollev.com/JulieKutak224. And there will be some opportunities for you to get involved with the presentation. Okay.
I'm also adding the link on the chat box. Sorry.
Oh, perfect. Great.
You know.
No, that's great. Okay, next. So could we actually go backwards? So I want to begin just by sharing where we're going to be going in this presentation, okay? So there are kind of four main areas that we're going to talk about. We're going to talk about communication at the end of life, generally, talking about some barriers to communication and ways to transcend those barriers. Then we'll talk about specific considerations when working with Latinx families at the end of life. Then we'll transition our attention and talk about particular challenges that are posed by COVID-19. And finally, some ways to transcend those communication challenges. So you'll see that the four are kind of discrete areas, but they overlap and they build on one another. So I just wanted to tell you where we're going, and then at the end, we'll talk about where we've been. Okay, we can move forward. Next. So in the poll everywhere, I want to gauge how comfortable folks feel with having end-of-life discussions. So all you have to do is tap one of the emoji signs on your phone, and it'll start appearing on the screen. So how comfortable do you feel having end-of-life discussions? Uh-oh, I don't see them coming up.
Sorry, Dr. Kutak. It says waiting for the presentation to begin. It's like for some reason it's not reading that the presentation is going on right now.
Oh no. Okay. Okay. Well, we will let me see if I can make it. Okay. Well, we'll just skip that. I will imagine that there's a variety of different areas. I'm sorry about that technological glitch, but we'll move forward. Okay, we'll go to the next slide. So let's talk about communication at the end of life. So there are just some general considerations that I want to kind of just take care of at the start. One, you can be a really nice person, but having to deliver the kind of difficult, hard news that occurs at the end of life can be so challenging. It really is a kind of skill set that you develop. So you can be the nicest person and say things that may be unhelpful or just not know what to do when you get into that situation. And I like to give all people the benefit of the doubt and to approach them with an ethic of generosity. I think people are usually trying their best, but at the same time, we as humans have kind of an overwhelming desire to minimize our own pain. And in trying to minimize our pain, we may inadvertently increase the pain of others. So it's not because people are bad in any way, but it's generally just because they don't know what to say and oftentimes fumble through it if they haven't had any kind of training. Next. So there are some significant barriers to communicating at the end of life. And we're going to go through each of these one by one and talk about them. Let's start by talking about a misunderstanding between the difference between disease and illness. Okay, next. So there is really a dichotomy between disease and the experience of illness. And I think a lot of patients come into the hospital and they are having a psychosocial experience where they are feeling what their disease feels like. They are worried about the experience for themselves or for folks that they're associated with, like family members or friends. But oftentimes, healthcare providers are more focused on managing the pathological processes, the physiology, or the psychological processes in an individual. So, for example, you could have significant heart disease, but you may feel fine and not have any experience of illness. But at the end of life, there can be a merging of this illness experience with the disease processes, but without understanding and recognizing that disease processes are embodied in people, and people are complicated and they have needs and desires and wishes and hopes, and they may experience illness in different ways. Without fully understanding that, you can't work towards robustly healing the patient. Next. The sociologist of illness, Arthur Kleinman, has a great quote when he says, "Healers seek to provide a meaningful explanation for illness and to respond to the personal, family, and community issues surrounding the illness." So diseases happen in bodies, but illnesses happen to people, the souls that are sort of, living inside the body, if you will. Next. Another barrier to communication is a lack of understanding about the grief that families may be feeling towards their loved ones who are dying. So anticipatory grief is an unconscious process when a person is facing the death of another person. It's a process of letting go and kind of rehearsing what the future is going to be like without the loved one present. And so the person who is expecting the death of another may grieve in ways that are as strong as grief after death. They may, and they may not understand what's happening. They may not understand that they're starting to make this kind of separation, but oftentimes the person who's dying can feel that separation happening, and it can be troubling for them. Or they, in turn, in doing the work that they're doing to die, may let go as well. So there are these dynamics that are happening, but they often aren't articulated. And so knowing that anticipatory grief is a phenomenon that happens to families can be helpful for providers. But by not acknowledging it, that can be another barrier towards strong communication. Next. Another barrier is denial, which is not just a river in Egypt, as Mark Twain says. Denial is a coping mechanism. In fact, it's one of our most primitive defense mechanisms and coping mechanisms, where we act as if the painful thing that is happening, the painful event, the painful thought or feeling doesn't exist. And I want to be clear here that when someone's in denial, it doesn't mean that they don't know that the reality is happening. They may know that the reality is happening, but it feels too painful to deal with that reality. So the person acts as if nothing is really wrong. And it's really rooted in fear about what the future is going to look like and fear of the unknown. So denial is a very natural coping mechanism, but it's not the most healthy of coping mechanisms. And when families can't get past their denial, that may be a strong barrier towards communicating what values and preferences the person who's dying has at the end of life. Next. Additionally, there are so many emotions that both the dying person and the family of the dying person are feeling at any given time. It's almost amazing that so many emotions could be in one body at one time, and they're all like vying for the same real estate. And I'm happy to share a personal story. After my father died, I felt worry about the future and sadness and anger at him for dying, even though I knew that that was unreasonable. I felt guilt that I felt anger. I was confused at what life was going to look like without my parent. I had resentment at strangers and other families who still had their father. That felt really unfair to me. And these emotions might ebb and flow depending on the time of day, depending on the day of the week, depending on different sort of environmental triggers. So not knowing how to sit with those emotions can be a huge barrier to having strong and healthy conversations. Next. But I want to say that these emotions aren't just happening inside of the family member or the person who's dying. They are also happening to the care provider. And it's a really hard job to be the person who is having to manage the emotions, to manage the fear of the unknown, to pull someone out of their denial in a compassionate way that's responsive to their needs. And so one fear that providers often have is looking weak. So they work really hard to manage and control the things that can be controlled, say, fluid levels or medications or paperwork, things that they can do in order to postpone or delay those difficult conversations that are painful. Remember, humans have this, really strong desire not to be in pain. And so we do healthier and less healthy ways of keeping ourselves from that pain. So as we move forward, we're going to talk about strategies to sort of sit with that pain and to deal with it in constructive ways. Go ahead. Next. Yes. Oh, and there's always a fear of our own mortality. And that connects to this feeling of a lack of control. Death is that thing which cannot be controlled. It's the ultimate unknown. It's what is beyond it is completely and totally unknown. It may be something, but it may be nothing. But how can we even talk about nothing? By talking about nothing, it becomes something. So we're in this tensive relationship with death, and not being able to understand what happens. Only the person who dies truly understands what the experience of death is. There can be a real feeling of a lack of control, both on the part of the provider and on the part of the family. It's very hard. Watching another person die or deal with their own mortality necessarily calls up our own experiences of our own worries about our own mortality, our anxieties. The philosophers call it angst, that unknowable great anxiety that it can hardly be described. It can really only be apprehended. You know, it often hits us at 2 a.m. when we realize that not just everyone's gonna die, but one day I'm gonna die. And I'm not everyone, I'm me. So that there's a lot of emotional baggage that's connected to the end of life. And all of these work in, concert together to provide barriers to just having frank conversations. Okay, next. So how do we help families overcome these barriers? Next. The earlier you can have these conversations, the better. And you have to approach these questions in a curious and compassionate way, and encourage having the discussions early and often, where you articulate and talk about what your deepest held values are and what your goals are for the future. Next. So there can be lots of different potential goals of care. When talking about the end of life, the goal may be to cure disease. It may be to prolong life, but it may be that a person wants to simply maintain their quality of life, or maintain some kind of function, or relieve the pain or the mental or emotional or spiritual suffering that a person's feeling. So curing disease or prolonging life is only one part of the potential goals of care. I know of one person who was dying. When finally someone asked them what their goals were, this person had head and neck cancer, and they wanted to be able to eat ice cream. That was the extent of their goal. As long as they could eat and still enjoy ice cream, then they felt like they were maintaining a good quality of life. I don't know if that would be my goal. I don't know if that would be your goal, but I can guarantee you that our goals may not be the same. And the only way to know them is to ask the question. Next. So at times, some may take priority over others, but here, let's look at some of these questions. So here are the questions that you can ask to help articulate those goals. What is the illness really looking like? What is the true trajectory? And that involves frank and honest discussion about what the potential is for cure or for management of the disease. And I think in one of those opportunities to prevent our own pain, we may provide false hope to patients. So what do you hope the treatment will do? What are the goals of the treatment? How will the treatment make the patient feel? What is it like to die of the disease? What does it feel like to die of the disease? To the extent that that can be known. How can medicine ease the symptoms? And what are the pros, cons, and alternatives to the treatment that's being proposed? And finally, when do patients with the disease that they have benefit from enrolling in hospice? So these are practical questions that can guide the conversation. And as we move forward, we'll talk about further strategies as well. Okay, next. So let's move past the poll everywhere since it's not working. Next. Okay, so the tips and barriers that I talked about. Oh, can you go back, please? Thank you. Oh, one more. There we go. Are true of all humans. I believe they are true of all humans. And as we talk about Latinx families specifically, I want to make a cautionary note to beware generalizations. Next. We can say that one family, that there may be trends that we can look at, but if you've met one family, congratulations, you've met one family, right? So I always take an approach when thinking about working with populations that are different from me, which is every population, right? Not to take an approach of cultural competency, but rather take approach of cultural humility. So what do I mean by this? Cultural competence suggests that there's an endpoint, that you could develop expertise in saying, I know about this community. And you make decontextualized generalizations like all people do X. And it sets up a relationship where the majority is what's normal and other cultures are different and are working in relationship against what the majority culture says. But when you take a more humble approach, you are recognizing that different sources originate, that different contributions originate from multiple different sources. You recognize that power differences exist that must be respected. You recognize that the person who is asking the questions must be reflective and must always make their biases explicit and recognize that they don't know everything. There's a flexibility and a humility that comes along with taking approach of cultural humility rather than competence. So I say all of this to say, in the next few slides, I'm going to make some claims about some trends, but recognize and realize that these are only starting points for conversations. In no way do I want to suggest that that these are blanket statements about all Latinos or Latinas. Okay, next. So in the public health literature, there have been some differences and evolution among Latinx families that can be sort of seen along generational lines. First generation Latinx families are often more conservative, while the second generation, or if children immigrated while they were still young, but then went through their teenage and adult years in the US, they tend to be more acculturated. Language use often drives acculturation. When you speak the language, you can understand you can understand the world in a way that's often prohibited to the people who don't speak English. So often folks who don't speak English tend to talk to other people who speak their language. It's very reasonable. And so they don't make as many relationships across, cross-cultural relationships. So they tend to be more conservative and adopt the values of their home country. Next. There are also socioeconomic status implications. This is a little bit of a hard slide to read, but let's go through it. So depending on the socioeconomic status, folks may have an easier or harder time accessing resources. All people need culturally sensitive care, but folks who have a lower socioeconomic status or a lower middle class may need a bridge. So they may need to have folks in the community and receive information from folks like community health workers or promotores that can help facilitate connections between their community and the English-speaking community. Gender and family norms are also shifting. Marginalized minority communities, low SES communities may have a more traditional family structure than those who are middle to high SES, where there are shifting trends and more and potentially more egalitarian relationships. In lower to middle SES, gender and family norms may be changing, and there may be conflict among the families where younger people are resisting the more traditional roles that their parents or grandparents adopted. Community characteristics change. The lower marginalized communities are often hidden. They're often they may feel reluctant to share information about themselves, and there may not be a lot of trust, and there may not be a lot of reason for them to trust because of their vulnerability to exploitation and the history of exploitation of marginalized communities, both in the past and ongoing. Those who are in the middle SES may also be reluctant, and they may want to go back to their home country eventually, but they are concerned about what they have to invest in order to be able to return. Higher SES communities, higher SES families, may be very busy, and they share the stressors of the more dominant U.S. community, but they still may be living with an internal experience of feeling like they're different, that they're other. There just may be a sense of not necessarily belonging. And then finally, socioeconomic status drives heavily the relationship that a family may have or a patient may have with their country of origin. The more money that there is, the more that they may have the ability to make contact and travel back and forth. But whether they can travel back and forth, that doesn't necessarily mean that the desire to have contact is not there. And so dealing with families who are separated and who can't communicate with each other as much as they would want to can be a real source of stress for families. Okay, next. There are also regional geographic differences. Traditional gateway states like Florida, Texas, California, or Arizona may have more established communities. There may be stronger bonds with common language and culture. Folks have been here over multiple generations, and so they have elders to rely on, and there are younger folks, and these communities are very multi-generational. But emerging and incipient markets, for example, states that are fast growing, where there are new communities of Latinx, there may be fewer established cultural resources. The community may skew younger. It may skew more male as folks, as men come over to work, but their families are back home and they're sending money back home. So there's a lot of growth. The growth is fast, but they may not have the same kind of cultural resources and the same kind of community bonds that can help them in times of need. Next. So these are some possible points of view. Knowing all of that, knowing the levels of complexity among families, both generationally, socioeconomically, and geographically, these are some possible points of view and trends that you may see. The people may believe that they have a lack of control over their destiny. And so there may be a sense that everything is preordained and they have little control over what's happening. This can be a coping mechanism, but it can also cause people to be fatalistic and not take the things that are being offered to them. There may be a sense of beliefs in good and evil forces acting in the world, and that connects to the belief in the lack of control over destiny. There may be a sense that the family is prioritized over individual needs. And so we often take an approach where we're focused solely on the patient and the patient's values and the patient's preferences. But for Latinx families, we need to be very sensitive that may not be what the person actually wants, that the person wants their family involved. There may be a strong respect for social hierarchy and confidence and trust in health professionals. So as a provider or a person who's working on the healthcare team, you may have quite a lot of say, and you may have your patients sort of defer to you, which can be kind of juxtaposed to the idea that we value patient autonomy and we want to do what the patient wants. But the patient, in honoring their jerarquismo and the confianza, may want to rely on you as a means of showing respect to you. So it's important to pay attention to these, to these possible points of view and to help your families articulate what these points of views are. And so you can ask them about it. Very, very rarely do people get upset when someone asks them a question in a curious, compassionate, and empathetic way that really wants to know more about them. They're often happy to tell you. And it helps build relationship. Okay, next. So communication, so COVID-19 poses its own set of communication challenges. Next. And it really throws into relief the challenges of some of the strategies that we talked about. I mean, it's really nice to be able to have end-of-life conversations early and often and in safe spaces where there's not a lot of stress. But that's often not the case when people are dying so quickly and they're in hospitals and they're unable to see their loved ones. So I want to talk about challenges for patients, challenges for families, and challenges for providers. Patients. Oh, I'm sorry. Can you go back? Patients may be experiencing lower levels of social support because they're isolated from their families. and particularly Latinx families who have strong relationships with their families, to not be able to be with them because they're isolated in COVID units can truly exacerbate the kind of existential loneliness that causes suffering at the end of life. So for the last month, I have been working as a chaplain at UTMB, going in and out of rooms, not with COVID patients, but our regular inpatients have not been able to have family visitors because of the fear and very real threat of infection. So I went into these rooms, and these are families that can still, these are patients rather, that can still talk to their families over the phone. But I went into room after room where patients were so incredibly lonely. And so to be both lonely and to be in COVID isolation it just compounds the experience that the patient may be having. Okay, next. Families may also be struggling. One thing that is really terrible about COVID is that people may be sick, they may be ill, and then very, very quickly they decompensate and they move from this quick transition from ill to dying. And so there's an inability to say goodbye. Families may also be experiencing severe anticipatory grief because they've been thrown into this experience where their loved one has become sick so quickly and has moved from this quick transition from ill to dying. So there can be many, many different sources of guilt. Guilt that the family can't be there to say goodbye. Guilt that they are not sick while their loved one is dying. That kind of survivor guilt can be significant as well. And finally, there can be experiences of disenfranchised grief, because when so many people are losing loved ones, what makes my grief more important or more special or more real than that other person's grief, right? So this idea of disenfranchised grief is the idea that it's not appropriate to be grieving. It's not socially appropriate to be grieving. And so while, rationally they may think, well, I've lost a loved one and it's certainly appropriate to grieve. It's when we're constantly bombarded with these media images of people dying, it can complicate the grief and it make it less okay. And we've all had those experiences too, of losing someone, and then you're allowed to grieve for X amount of time, and then there's kind of like some sort of terrible cultural assumption that now you're supposed to be sort of getting on or moving forward. That is the idea of what disenfranchised grief is. So these are huge challenges for families who are dealing with loved ones who are dying of COVID. Okay, next. There are also challenges for providers. Providers may be working to allocate scarce resources, and they may be asked to do things that they feel are morally wrong. And that's what instigates experiences of moral distress. So in a time where so many people are sick on a ward and resources are scarce, not everyone can receive the same level of care. So there may be huge experiences of guilt on the part of the provider. Furthermore, the provider may be isolated from their own networks of care. Because the provider is continually being exposed to the disease, they may have to They may be living in another part of the house or not being able to connect. And I will say my sister-in-law is a physician on a COVID unit, and I can understand to a certain extent what she's going through, but I can't understand fully, and I can't emotionally understand fully. Touring, when I was up on the COVID unit, watching people and looking around, just the performance of having to wear the PPE all the time and the separation and the fear of getting close to people was so intense. And that, those emotions they're present inside of us, and they're, without being recognized, they can really contribute to experiences of suffering. And also, providers may be experiencing disenfranchised grief as well. They may not have lost a loved one, but they have lost patients of their own. And so the grief that they're feeling may be very real, along with those very human feelings of lack of control or fear of looking weak. So all of these things are of a piece, and they're all sort of exacerbated, highlighted, and exaggerated by the challenges of COVID. Okay, next. So the consequence for all of these things are predictors of complicated grief. And complicated grief is different from simple grief. So simple grief is the kind of grief that you experience, you work through, and in time it lessens. Complicated grief is more challenging, and where emotions are heightened. Bitterness may be excessive. It may be hard not to ruminate on thoughts. There may be difficulty with accepting the new reality of the world, post loss, and it can lead to a perceived purposelessness of life. So these are huge mental health challenges, and they're exacerbated by the pandemic. The type and volume of loss may mediate the likelihood of complicated grief. So the more loss, the loss of a person, a patient, a family member is particularly close to, or a loss that happened when the family couldn't be present, those may increase the likelihood of complicated grief. So our role as providers is to work as this kind of mediator, to help be a stopgap between the experiences that the person's having and the potential for this complicated grief. The grief will happen. It will happen regardless. But to help the family welcome the emotions and understand that grief is natural and does not last so intensely forever, can be a benefit that you can give to your families. Okay, next. So I'd like to stop right now for a couple of minutes to see if there are any questions before we move on and really talk about the strategies for more strategies for improving communication at the end of life. But I just wanted to be sensitive to the fact that y'all may have questions right now, and if I can answer them, I will. And then there will be another opportunity for questions at the end of the presentation.
Yes, we have the first one. It says, how do you address death or dying in the context of medical distrust? An example, when the family has a reason to believe there may be implicit biases influencing a medical provider's prognosis.
That's a great question and a very hard question. It reminds me of an experience I had when I was working as an ethicist up on a unit, and there was a family that significantly mistrusted the physician, and the physician was being a real toot. I mean, there's just that's the most polite way I could say. And the patient had an anoxic event and was, for all intents and purposes, in a vegetative state, but the family was hoping for a miracle, and they also believed that the physician was not telling the family the truth. And it was so hard, and the physician was ready to override the family's wishes. And at that point in time, a different physician had to come in because the relationship between the family and the first physician was so damaged. The second physician came in. He sat the family down in a room that didn't look quite so clinical. It was a softer room, and those aren't always available, but at least it was separated from the hospital room that their loved one was in. And he started asking them questions and got to the root of their mistrust. And it turned out that they had another loved one who had died in the same hospital only a few weeks prior. And so they hadn't really gotten over the loss of their other loved one before their second loved one was now in the same hospital dying too. What it took was that physician coming in and sitting down with them and not imposing any kind of agenda on the family, but rather letting the family be there in all of their anger and hurt and mistrust. And the physician had to absorb that. But in doing so, he created a kind of space that was opening and honest and welcoming in a way that the other physician had not done. I don't think that kind of work is impossible, and that's one of the things we're going to talk about in the next section about how to do that. Next question. Okay.
Sorry.
That's okay.
Okay. We have a couple. So it says COVID-19 could certainly exacerbate complicated grief. So many ways that families normally grieve are unavailable to them. What suggestions do you have to help with this?
Yes. I'm going to ask you to hold that question, and I want to talk about it in the next section. I think that's a really important question as well. So y'all are looking ahead to the next section, and I'm really grateful for that. So let's go ahead and move on, and then we'll take more of those questions at the end. So yes, these opportunities for grief are not available to them. So how can we overcome some of these challenges? The first is this is a concept that comes from Arthur Frank, who is a literature and narrative scholar as well as a medical sociologist, and he talks about the clinician as moral architect. This is one of my most favorite concepts. It's the idea that as the healthcare provider, it's incumbent on you to create the space that opens the possibility for conversation. it's a space that's generous and open, and it takes time, but it doesn't take as much time as you would think. It's really not just something that you do. It's not a checklist to offer, but rather it's a way of being that builds on the idea of humility, but that sees the other as a friend, as someone who is vulnerable and worthy of respect. And I know we do this generally, but we have so many outside pressures that impede on, and that sort of nip at the edges, that keep us from being able to have that kind of deep emotional connection with patients and their family members. So I look to you to craft that space, and to do it in a way that exposes your own vulnerability. There's a sense that if the clinician doesn't look powerful, they don't know what's going on. They'll be perceived as weak, and there won't be trust. But I would argue there's a different way of thinking about it. That when you present yourself as another human who also is suffering, who also is experiencing these emotions, then you become humanized to the family and the patient in the same way that the patient and the family becomes humanized to you. Next. So this is the definition of cross-cultural care. It's encompassing compassion, empathy, responsiveness to the needs and values and expressed preferences. But focusing on the compassion, the empathy, and the responsiveness, these are also the hallmarks of being a moral architect, of creating the moral space that allows the preferences, the needs, and the values to be articulated. Next. So as I hope I've made clear, I believe that every interaction with a patient is cross-cultural. Every patient, every family deserves to be approached with this kind of respect and curiosity and big-heartedness and really generosity, to know where their particular sources of pain are, and potentially sources of joy. Next. So the ABCDE model is an acronym that you can use to help you with this. The first is the attitudes of families. Next. So what does the illness mean to the patient? What does the patient, and in this case, the family, hope for? What are their beliefs? Does spirituality or religion play a role in their life? And if so, how can we attend to their religious beliefs? Get to know the patient. What were the most important times in the patient's life? And if the patient is unresponsive because they're isolated in the COVID unit, ask the family to tell you about the important times in their life, how long they've been in the US, what types of things helped shape who they are. Understand how they make decisions, who makes the decisions, and who should be present in decision making. And finally, are there community resources that are available that can help families afterwards? Okay, next. So what I'm asking you to do, I mean, this all This is not stuff that's measurable. When I'm asking you to be a certain way, you can't put that in a, as a data point. What I'm asking you to do is to foster this big German word, Zwischenmenschilichkeit. And I'm sure I'm butchering it. But what it is next is this German word that means that special something that happens between people when they're in sync, taking each other seriously, holding each other in mutual regard. I know that every one of you has had that experience, potentially with a loved one, a friend, a colleague that you care about, when you really get that other person and you see them as both who they are and as something more than who they are, as a member of the human race. So I look to you to foster those feelings. And in doing so, you can help to minimize the experience of grief that the family may be feeling. And I don't mean minimize the grief as in make it less, or diminish it in some way, but rather you're honoring it by holding them in regard, and you're creating a space where the grief doesn't have so much power that it obscures everything else. Okay, next. One practical, go ahead, can you go back? One practical thing that some providers are doing is putting a picture of their smiling face on their PPE. One question that I've received is how can you foster this kind of relationship when all you see is protective equipment and masks and goggles, and you're so separated and you can't even touch, and you have to stay 6 feet away? And it's a real challenge. I think one of the ways of getting around that is to have these faces that are smiling, that are welcoming, that show you what the person looks like, what the provider looks like generally. I also think calling out, naming the experience, both infuses it with meaning and takes some of the sting out of it. And what I mean by that next is understanding emotions as natural phenomena. What I mean by it is recognizing that emotions are temporary. There is not a single emotion that lasts forever. I know all of y'all have laughed so hard that you have maybe had tears run down your face, but you're not laughing that hard right now. I know I have also cried so hard that I thought I would never stop crying, but I did. And understanding that emotions are natural and unavoidable, but they're not good or bad. They're just a byproduct of us having a limbic system, right? They're natural, they're unavoidable, they are going to happen. And so responding to the emotions in more helpful ways can also help foster trust between families and care providers. Next. So one of the strategies that you can use to name and welcome the emotions, and help your clients do this too, is to imagine an empty chair in your mind. And go ahead. And to sit and think about what it is that you're feeling. What emotion am I feeling right now? and then ask it to take a seat. So if I'm feeling extreme anger, saying, I feel angry, welcome anger, you're part of my life, you're here, so why don't you have a seat? I'm also feeling extreme guilt. Okay, what does that feel like? It feels like an intense ball of anxiety in my stomach. It makes my heart race. Naming them, talking about how they feel physically. What it does is it gives you an opportunity to separate just a little bit from the experience of the emotion to be able to gain a little bit of control. And then instead of having a reaction to that emotion, you can respond to the emotion. So go ahead. Next. So you want to approach each emotion with detached curiosity, not becoming overwhelmed or consumed by it, but rather welcoming it to the human party that is life. Okay, go ahead. Other practical strategies that you can use are including families through technology. We have used some iPads to help providers manage calls between families and their loved ones who are in isolation. I know that some hospitals are using tablets to have their patients talk to their healthcare providers, and that's good. But I think it's even better to be able to have families see their loved ones on the tablet. I know that some families, I know of a family here at UTMB who was able to say goodbye to their loved one while their loved one was in the COVID unit before their loved one passed away. Does it replace being at the bedside? No, of course it doesn't. But after the patient died, the family reached out and thanked the healthcare team for providing that opportunity, because at least it was able to provide some kind of closure, or at least a moment of closure. There's also some good research that's coming out that is saying that Google Translate can be a resource for families. It does not replace live translators, but it can be a stopgap if translators feel uncomfortable going into the rooms because of isolation, or if there's not enough PPE. Then Google Translate can be an okay solution. Do carefully consider the logistics of operationalizing this. At UTMB, there were some real deep, pretty intense discussions about where the tablets would live, which department would be in control of the tablets, how the tablets would be checked out. Eventually, like for example, pastoral care got one tablet and they were able to use it while other departments had more tablets. It takes a budget, but this can be a strategy. Also think about how they'll be cleaned after each use. So these are unusual times. These are not permanent solutions, but they can be stopgap measures to help foster relationships in a time when isolation is so real. Go ahead. I want to close with some other considerations for you as providers to help you maintain the kind of emotional strength that it takes to then be able to give your clients and your patients the kind of consideration and deep attention that it takes to provide that kind of generosity towards your families. So these are considerations for you. Go ahead. Now is truly the time for radical self-care. I encourage frequent body scans where you're just like closing your eyes and moving your attention to each part of your body and locating where you're holding stress, taking deep breaths to help relieve some of that stress. Honor your own loss and recognize that this is a very difficult time. And, you know, your families may be in denial. You may be needing to approach them with the kind of love and honesty that recognizes that their denial is not helpful, but it's really unhelpful right now for you to be in your own denial. So honor the loss, give yourself space to grieve, and rely on your networks. Embrace spiritual practices to the extent that they're meaningful to you, but they may not be necessarily religious in nature if you are not religious, although if you are, there's a wide variety of religious practices that you can rely on. But even just things like deep breaths, meditating, and focusing on mindfulness can be helpful. Next. There's a beautiful prayer that Hadley Kiffner from the University of North Carolina healthcare system wrote, particularly as a way of grounding yourself when you're having to put on PPE. And I encourage you to read it on the handout. It has beautiful phrases like, may my body be grounded in service. May my words offer encouragement. May I see the person and not just the patient. And may this encounter be safe and healing for all. And then after the encounter, next, there's a prayer for taking off the PPE. May I release all stress and let it go. May what I offered be enough. May I feel fresh and clean and safe. May I see through the lens of compassion. May I exhale and feel deep gratitude within. So this prayer may be appropriate for you, but even if you're not donning and doffing PPE, I hope that these words can be helpful for you as you're thinking about ways that you can approach your patients and your clients. Next. So in conclusion, end-of-life communication can help families manage their grief. And while there are special communication challenges posed by COVID-19, I encourage you to build communicative bridges based on creativity and generosity. And by doing so, you can approach Latinx families with a recognition that they're unique, and that the trends that I've offered can serve as a starting point, but that your moral fortitude and vulnerability will be the key to building a communicative bridge with your families. I'm happy to take more questions. Next. And the last page is the references, just FYI. And this is a picture of the island that I live on. I always think it's nice to end. We certainly can't attend, we can't go to this little amusement park right now, but I look forward to the day when we can all be at least together in the same room again. So I'm happy to take your questions and talk more, and I'd really love for this to be as conversational as possible. So I'm certainly happy to answer questions, and I'm also happy to hear your stories if you can type them out a little bit.
Yes, we have, I would say a story. It's a little
Okay,
bit
good.
long. It says, yes, providers can also be traumatized and be experiencing secondary traumatic stress. My father died of COVID, and we were told by his doctor that we were putting her staff at risk every time someone had to go into my father's room. We were told this just before a conversation about whether or not to take him off a ventilator. The stress of caring for so many severely ill patients was getting to the caregivers, and they were passing on to us as a family. For us, it translated into them questioning why we would continue to put hospital staff at risk for someone who was going to die.
Oh, I'm so sorry. I'm so sorry. What a tragic example of how the lack of self-care can bleed on to innocent families who are dealing with one of the most difficult experiences of their own life. I'm so sorry that that happened, and I hope that you'll rely on your community networks and the people who care about you, and let them care about you. You know, let them love on you right now, because I know there are people in your life that want to, even if they're not reaching out, they probably want to. So don't feel like you have to have it all together right now. I'm so sorry that happened.
Yeah, and that same person asked a question. It says, what suggestion do you have when navigating language barriers? There is research that suggests that when English is a second language, level of care can be diminished, and that use of interpreters is sometimes not deployed quickly or not readily available.
Yeah, that's an ongoing struggle. I hope that more education to healthcare providers about the importance of translators will help sort of facilitate a culture change. Our translators are absolutely phenomenal, and there are maybe 10 of them, but there are so many more patients who need them. So things like Google Translate can be a help, but they're not, um, it's not foolproof. What I would say though is a strong resistance against using family members as translators, because I think it's a really unfair and dangerous position to put a family member into the role of translator. But I wish I could give you an easier answer about how to make it better. I just hope that in the work that healthcare professors are doing, that we continue to raise the next generation of providers to be sensitive and to know what resources are available so they'll use them more quickly.
Thank you, Doctor. Another one says, can you talk about how children go through the death of a loved one due to COVID-19?
I didn't study that particularly, but I imagine that their grief they may experience the same kinds of challenges. They just have less of an emotional vocabulary to talk about it with. So I'm speculating, but I could imagine that they may experience outbursts or some kinds of regressions. Oftentimes their emotions come out in physical ways. So there may be a few like developmental regressions or bedwetting or things like that. But they need the space to be able to talk about their big emotions too. I'm happy if the person who has this question email me about it, and I will do some research, and I'll be happy to get back with you with a better answer.
Yeah, we just received something that's related. It says how to explain a child that mom or dad may not come back from the hospital.
Yeah. I'd like to look. I don't have a lot of experience with pediatrics. My focus has always been on gerontology, so I don't want to speak out of turn, but I would be more than happy to look that up and to get you in contact with the people who could answer these questions.
Yeah, thank you. They're just answering. And somebody also gave us a link to a PDF. I think it says something, let me see, helping children with traumatic separation. And
Oh,
it's from the
thank
NCDS, and I'm gonna copy that for everybody on the chat.
That's great. Thank you.
Okay, there you go. Everybody should have it now. I see people sort of clicking the hand thing. You could just go ahead and put on, like, write the questions on the question box, and I'll just get it right there, because I see people clicking the hand thing, but it just lets me know you guys are clicking it. It doesn't show anything else. So if you have a question, who's ever clicking that, just go right ahead and write it on the question box. And then we're getting many comments about such great presentation that you've given us today.
Thank you. Yeah, I think that a lot of this is preaching to the choir, right? I mean, I know y'all are out doing such amazing work in the world. So if nothing else, I hope this can be a booster shot to encourage you to keep up that work that you're doing.
Oh, and someone, let me see. Someone was asking about a prayer. I don't know if it was a prayer you shared.
Yes,
They
the
wanted
dawning and adopting.
or I don't know if they were asking where to find it.
It's the whole prayer is here on the slide. But also if you just go to Google and type in PPE prayer and Chaplain Hadley Kifner, you'll be able to find it. I think I might have put it in the references as well.
Yeah, and if anybody has any issues downloading the handout from the panel, you can just email us and I'll make sure I attach it to the email. We have another question. It says, any suggestions for managing family interactions when younger and or more able family members try to manage care when it's not clear that it is the patient's wish?
Yes, yes. I mean, in the end, the patient is the one who makes the decision. And if not the patient, then their surrogate that's been named in their advance directive. So I think it may involve multiple conversations, but continue to explore the motivations for why this family member is wanting to work against the wishes of the patient. So find out what it is that's driving it, because I can guarantee you there's an emotion, whether it's fear of death or fear of inadequate care. But if you can get to what the fear is, then you can address what's motivating it. But it involves building trust with the, with a family member too.
Thank you, Dr. Kutak. I guess since this is a rather difficult topic, we're not getting that many questions. I mean, everybody keeps saying that it was a great presentation, that they like the way you handled the topic and all that, but I guess everybody's shy. I mean, it's,
Oh, that's okay.
I guess.
That's totally fine. I mean, I've given folks a lot to think about, and oftentimes, the questions come later, if at all. So, well, I'm really grateful for your time today, attention, and thank you for the work that you're doing.
Thank you so much, Dr. Kutak, again for the wonderful presentation. I truly enjoyed it. And I want to let our participants know that if you come up with any other questions that you may have as you process all the information, you can email us or Dr. Kutak, and we'll be happy to share the information with you. So again, thank you to our participants for taking the time to participate in our webinar, and to Dr. Kutak. I want to let our audience know that as you leave today's webinar, you'll be redirected to complete a brief survey regarding today's experience. So this is part of what allows us to continue to do the work that we do. So if we have our evaluations, that is part of what is needed to continue to do this work. So thank you, everybody, and have a great afternoon.
Thank you.
Thank you.